So thank you very much. I'm sorry for the technical problems um, between Mac and Windows. I realize in front of this audience, my talk is going to be very, very basic. Usually, when people come to you for an SI joint problem, they've been to many, many doctors before. And they've seen general practitioners, they've seen rheumatologists, neurologists, pain physicians, orthopedic surgeons, hip surgeons, spine surgeons, and in the end, they feel like they're left alone with their problem. And we all know what the patient complain of. Well, it's pain in the buttocks, I have pelvic pain, I have hip pain, I have groin pain, I have radiation down the legs, I can't sit no longer, or I wake up at night. And a specific thing as well is cramps that do not react to calcium. So when it comes to differential diagnosis, I give patients 90 seconds to tell their story. And after that, I try for myself to classify, do we talk about low back pain? Do we talk about spinal canal stenosis? And it's sometimes really funny how even neurologists cannot tell SI joint problems from a spinal canal stenosis. Spinal canal stenosis does have to be bilateral, symmetric. Then we've heard it this morning, and you've heard it yesterday, hip pain, which is always radiating down the inner thigh, never the outer thigh. Adductor problems, sacrococcygeal problems, then radiculopathy. And if you give this talk in front of neurologists, even neurologists sometimes cannot tell the L5 syndrome or S1 syndrome from the pseudoradicular irradiation of the SI joint. Well, in fact, it's very easy. If you have the foot included, then we're talking L5 or S1. If the foot is not included, then we're talking pseudoradicular, which comes from the SI joint. So the difference really is the foot. We've heard a lot about the tests. What I learned in medical school was the standing flexion test to see whether the SI joint is blocked. We have the distraction test, compression test, Patrick's test or figure of 4 test, flexion abduction acceleration test, whatever you call it, Genslin's test, and the Mennel is not even mentioned here, because if you talk about Mennel's test, you have to talk about 3 phases test, or if you talk to physical therapists, it's 6 phases test. So it gets very, very confusing. We all know that slide with all the different tests that you have to do, and people always talk how many of these different tests have to be positive in order to talk about the SI joint really as a problem. And that reminded me at the early days in orthopedics where we needed to have 3 or more positive meniscus tests before you could run an MRI or fibromyalgia. How many tests, how many tender points do they have to be certain of the diagnosis? And you've seen that picture before. I found that very, very confusing. If you look at all the yellow arrows, you realize that none of these tests is actually specific, because you always move the facet joints, you always move the hip joints, and there's no test where you really move only the SI joint. And it's funny to hear that the Japanese have gone exactly the same way. We had the 14-finger sign, I called it. It was called finger test. I don't think it's a test, it's a sign because the patient shows you. And we've developed the PSIS distraction test. And this was 2008 when we thought we need a test where we stress on the ligaments of the SI joint without touching the facet joints, without touching the hip joints. And the videos I'm going to show you are vintage. They're from 2008, but I still like them. So you see negative on one side, positive on the other side, and that's a thing you cannot fake. So while people sometimes know if you do a LASIK straight leg raising test, they know when to scream. With this one, they can't fake it. So the problem was this PSIS distraction test was not validated. So we conducted a study to validate this test against all other tests. And we had basically two arms. We had the patients that had a positive intra-articular reaction to almost 100%. We took those patients and we did all the tests with them and compared the PSIS distraction test to Gensl's, Faber's, thigh thrust, and so on. And we had a control group who had no history of low back pain, and we did exactly the same test just to see if someone does not have pain back there, are there certain tests that do elicit pain just because you test them? And the results were quite clear. The test had a sensitivity of 100%. Specificity, not that good. So almost 90%, but this is like a COVID test, which you can do at home. If you press back there and you have pain, you are sure you will not miss a possible SI joint problem. It doesn't mean it has to be the SI joint, but as a screening test, it's very, very sensitive. On the other hand, if you compare the other tests, pelvic compression, distraction, thigh thrust, Faber tests, actually Gensl's was the only one reaching a sensitivity of 35%. That means you miss 2/3 of SI problems just because you're not able to have a sensitive test. The good news is if you have a positive Mendel's test, Gensl's test, then you know for 90% that it might be the SI joint. So we do have a validated test with a control group, injection control, that is very sensitive as a screening method, nothing more. So we needed something specific. So if we're talking about COVID tests, that would be the PCR test. And of course, here, that is a picture that you've seen already this morning. We started with the intra-articular injections. Now the problem in my hands with the intra-articular ones, the contrast agent hurts patients by itself. And the volume of the SI joint is so small that you fill the joint with contrast agent that is hurting the patient, and then you have almost no space for your local anesthetic or cortisone or whatever you put in there. And if you look at the innervation, the whole innervation of the ligamentous part of the SI joint comes from the medial branches S1 to S3 and from the dorsal ramus of L5 and the medial branch of L4. That means if you have to test all these, you have to test a lot of extra-articular nerves as well. And since last year, our neighbors, Germany, they have come up with a huge work. It's like 120 pages on what they have to do to test while they inject the SI joint before they're allowed to do a radiofrequency ablation. Now, this has become a real problem for us because we are forced to add the extra articular infiltration before you're allowed to do something percutaneously on the joint. And if we do surgery, which is much more than just radiofrequency, we have to adhere to those guidelines as well. Otherwise, if you do not add the extraarticular infiltration, it can be looked at malpractice. So the way we do it nowadays is if we have a patient that shows us where it is, we have the screening test, and then we do the injection, and this is real time now. We start with the intra-articular portion, like we used to do, which you can see on the right-hand side, and we go very high, just underneath the overlap of the ilium to make sure we don't have the sciatic nerve involved after local anesthetic injection. And then we move the needle out and slide it along the ligamentous part of the SI joints to the north, and we stay away from the neuroforamen to make sure no one can tell, well, you had too much local anesthetic running into the neuroforamen. This is like a sacral block. So it's not. We stay very lateral and include all medial branches from S1 to S3 as far lateral as we can. And once we've done that, we add another one, which is slightly distal and slightly lateral to the facet joint, so that we get the extra-articular portion as well, according to the guidelines, but it cannot be confounded with a lateral band block of L5. So a lot of work that we do is ruling out differential diagnosis. And how we do that? We have a screening test. We know it might be the SI joint. We have a specific combined intra and extraarticular infiltration that proves the region is probably the region that hurts a patient. But we still need to come back to the pictures we showed before and rule out all other things. Facet joints, actually very easy to diagnose. When it's hurting when patients get up or hurting while they hyperextend, it's probably the facet joints. If it hurts while they're bending forward, it's the SI joint. Now, there's one tricky thing in between. It's the Bertolotti's syndrome, which hurts with hyperextension and additional rotation. Unless it's a Bertolotti's syndrome on the base of an incomplete fusion of S1-2, these one hurt when you flex. So we actually go for testing of neighboring structures before we offer surgery to a patient, and we do facet blocks, which then are specific, and you can tell facet blocks didn't help, but the SI joint combined block did. Spinal canal stenosis, very easy. We ask for SSEPs, somatosensory evoked potentials, and you can measure whether the patient has a problem in terms of spinal canal stenosis or not. Hip, we do a hip exam, hip injection, hip radiograph to exclude that. And here again, L5 as well. You test the EHL, you test the dermatome L5, and we do electrophysiological workup to prove that it's not L5 before we treat the SI joint. So there's a lot of work around the SI joint just to prove it's nothing else. And then you probably remember these from last year. We all know the results of our fusion techniques, and you see that there is remaining pain after 2 years. So what we do is we go for denervation, and we use something that we've learned from the early endoscopic treatment of facet joint pain. We do not use percutaneous radioablation, radiofrequency ablation. We do it under general anesthesia with a solution that is glucose-based, so we don't have an electric problems around the nerve. And using a mini endoscope, we use the same technique as for the facet joints for radiofrequency ablation of the SI joint after fusion. So we wait for the implants to heal, which is usually 6 weeks, and then we add endoscopic denervation of the SI joint. This can be the classic denervation, but it can be patients that have pain around the crista, sometimes gluteal nerve entrapments of the medial gluteal nerves. You have patients that have an additional Bertolotti syndrome, which is very easy to denervate at the same time. We sometimes have irradiations of the sacrotuberal ligament. That's also very easy to denervate if you go S3 and S4 lateral branches. Or you sometimes have to go all the way down to the coccyx as well. So we do a mapping while the patient is awake, the day before surgery, we draw it, and then we have this picture on an iPad, and we compare it to the intraoperative fluoroscopy to make sure we get exactly the branches that were painful during the denervation as well. So in summary, this is how it looks like. What do we look for during denervation? If you look at the picture on the left, it's very easy to say what is ligaments and what is nerve roots, because the nerve roots and the nerve fibers always have a little capillary vessel along them. And this is what it looks intraoperatively. And given the fact that sometimes we really have a trough across all the ligaments, that might impact stability, which is why we do not do this as a standalone procedure, but we combine it with prior fusion. So coming to an end, we have a screening, which needs a very sensitive test, which we have with the PSI distraction test or one finger test they use in Japan. It's the same. Then we confirm the diagnosis, which we do with a combined injection, intra and extra-articular. And then, and this is most of the work, we rule out actively every other cause to make sure we're talking about the SI joint only. Thank you very much.
You certainly make the ablations look very easy. Is there a learning curve, or what would be your advice for somebody who's just starting with that? How many cases does it take, and is it that easy, or is it pretty challenging?
I think it is that easy because there's nothing, structurally, there's nothing you can harm, except when you're around the corner of it. The lateral branch of L5 is potentially dangerous. If you slip anterior, you might have an L5 damage. Touch wood, I never had it, but that might be an issue. But and if you work on the S3-4 very distally, when you denervate the sacrotuberal band, you have to have a separate lateral access in order not to slip and damage the sciatic nerve. Yes, but other than that, it is easy.
Okay. And then you'd mentioned Bertolotti's, which I think is a common diagnosis that can be confused with SI joint, and it's hard. I think it's hard to differentiate the Bertolotti's articulation versus SI joint issues. Do you have any clues on how you can differentiate where the pain's coming from, because it's pretty close to each other?
Yes. So if you have hyperextension and rotation that hurts, then it's probably Bertolotti's. If it hurts with flexion, it's more likely to be the SI joint. And then we do injections of the Bertolotti. We start with a medial branch L4, dorsal branch L5, which are the two that innervate Bertolotti's the Castelvi region.
Sure.
And then additionally the contact itself. So we always add medial branch block L4, dorsal branch block L5, and then the lesion itself, separate from the SI joint, and then compare the two protocols. They're actually very easy to treat with denervation because we denervate L4, dorsal ramus, L5, upper border of the sacrum, lower border of the process, and other than they might be painful after 3 years and might come back again, that's an easy target endoscopically.
Fluoroscopic injections or CT guided?
Fluoroscopic.
Fluoroscopic. Okay.
Thank you very much for this speech. It's very interesting to hear about the distraction test. What do you think is the difference between the distraction test and the long ligament test described by Fleming?
I think they're doing exactly the same.
Thank you.
The only problem is
It was a good answer.
or the Japanese test. We all do the same test probably, and Mr. 14 was probably doing the same test as well. But
Well, no. 14, it was only pain point.
Yeah.
It was not a test. Point where I know him. Point where you have a pain. It's not the testing. It was just a pointing with the finger. It's no testing at all. So this is a test. It is pain. You provocate the ligament, and I think if you move it from side to side, you provocate a little more than if you just push it. So I think it's the same. So,
I think so too.
yeah.
The problem is it's the only one that has been validated against other tests. And that helps in the medical legal field at least. If someone tells you, well, how can you be sure we're talking about SI? Well, we have a test, we know it's sensitive, and we can prove it. So.
All right. Thank you very much.